Hello, everyone. Welcome to our Zoom meeting. Today, we will cover different topics, and Dr. Suhair and her team will be taking care of this meeting today. So, Dr. Suhair,
Hello, everyone.
when you are ready, I'm going to just hand it over for you. Thank you.
Thank you, Dr. Nader. Hello, everyone. My name is Suhair Zain Al-Abdin. I am the leader of the white team, and today we're going to present to you this Zoom session. I'll be the moderator of the session as well. And the first topic will be covered by Dr. Elaf and Dr. Esam, which will deliver the diabetes mellitus type 2 presentation to us. So Dr. Elaf and Dr. Esam, if you are ready, please go ahead.
Hello everybody, Assalamu alaikum. I hope you are doing well. My name is Elaf Sabri Khalil. I'm going to present diabetes in older adult. My colleague Dr. Esam, and I will be in the second part, inshallah. Can you make me the host, Dr. Suhair, so I can share my screen?
Can you try now, please?
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Esam, and I will start by talking about type 2 diabetes mellitus. In this presentation, we will talk about these topics. Number one, the epidemiology, classification, and the pathophysiology of diabetes mellitus. Number two, the management of type 1 and the type 2 diabetes. Number three, the complications of diabetes mellitus. Okay. Number four, the role of diet and the lifestyle in diabetes management. Number five, the advances in diabetes technology. Number six, the impact of diabetes on cardiovascular health. Number seven, diabetes mellitus and mental health. Number eight, the role of genetics in diabetes mellitus. Number nine, innovative therapies in diabetes treatment. Number 10, diabetes education. Now I will start by talking about the epidemiology. You should know that diabetes mellitus is considered to be one of the most common chronic diseases affecting older adults. And for adults more than 65 years old, 27% have diabetes. Some of them are diagnosed and some of them are non-diagnosed. But the general estimation is about 27% of the population above 65. And these older adults who have diabetes also have risks related to diabetes because their diabetes increases their 10-year reduction in life expectancy. So they have a 10-year reduction in life expectancy and mortality rate nearly as twice that of people who don't have diabetes. And this indicates how high can this diabetes affect the quality of life of these patients. Also, it affects these patients, especially the older one, leading to mobility problems, leading to disabilities in their activities of daily living, which means that it has a greater affection of their life. Let's proceed. The main types of diabetes mellitus indicates three types. Number one, type 1 diabetes mellitus. It is not as common as type 2. It is common in about, or it is prevalent in about 5 to 10% of the population who have diabetes mellitus. The pathophysiology of type 1 diabetes mellitus is autoimmune condition. where the body forms antibody and attacks the insulin-producing cells which are found in the pancreas, leading to destructions of these cells and absolute absence of insulin in these individuals. While in type 2, which is the most common form of diabetes mellitus, affecting nearly 90% of patients who have diabetes mellitus, it is associated mainly with insulin resistance and lifestyle factors, and we will talk about them in further details in the next few studies. We have also some rare types of diabetes mellitus like monogenic diabetes mellitus, and the most common type of them, it is called MODY. MODY is the abbreviation of maturity onset diabetes of the young. It is due to a single gene mutation, especially in the enzyme which senses glucose and secretes insulin by sensing glucose, and it is found in the liver. The name of this enzyme is called glucokinase or hexokinase in other cells, and this is one of the examples of monogenic diabetes. And as I said, type 2 is the most common, type 1 is the second most common, and monogenic diabetes and other types of diabetes are far less common. That's why in the next slide, we will focus on our main project today, which is type 2 diabetes mellitus. Let's proceed. So, pathophysiology of type 2 diabetes mellitus is mainly elevated glucose level. And this elevated glucose level may be noticed and may not be noticed. Elevated glucose level is called hyperglycemia. So the main problem in type 2 diabetes mellitus is hyperglycemia. And hyperglycemia means that either the insulin is non-sufficient or the insulin is not acting, or combination of both of them. So it is due to abnormalities in either insulin secretion or insulin action or both of them. And the type 2 diabetes mellitus was found due to genetic predisposition and environmental factors. All of them combined together are implicated in the pathophysiology of type 2 diabetes mellitus. Also, it is associated with obesity and the distribution of fat. And we have multiple types of obesity. So visceral obesity, in which fat accumulates around the waist, is the most common form of obesity that is associated with type 2 diabetes mellitus. I would like to hint that here there is no rule for autoimmunity, which is the main mechanism for type 1 diabetes mellitus. Here there is no autoimmunity at all. It is just associated with genetic predisposition and strong environmental factors, as I said, affecting either the secretion or action of insulin. Let's proceed to the next slide. There are 4 ways to establish the diagnosis of diabetes mellitus. The first one, which is the most accurate and the most used by physicians, it is hemoglobin A1C, which gives you a crude estimation of the glucose levels over the past 2 or 3 months. I would say that 6.5% or more on 2 separate occasions is considered to be diagnostic for diabetes mellitus. If the patient can't do the hemoglobin A1C test or has contraindications to it, so he may do any one of the other 3 tests. The second one, which is random blood glucose. It means that we will randomly measure the blood glucose level. If we found that the blood glucose level are more than 200 milligram per deciliter, which equals 11.1 millimole per liter, this indicates that this patient has diabetes mellitus, especially if the patient has signs and symptoms which are classic for diabetes mellitus, which includes polyuria, polydipsia, unexplained weight loss, and of course the elevated random blood glucose level. The third test which can be used is fasting blood glucose level, in which we measure the blood glucose level after fasting from eating any foods or anything that contains sugars for a couple of hours. If we found that the fasting blood glucose is more than 126 milligram per deciliter, this indicates that this patient has diabetes mellitus. The fourth form, which is the least common one, it is called glucose tolerance test, in which we will allow the patient to drink a cup of water contains a specific amount of sugar, and we will follow his blood glucose level for 2 hours. And if we found that the blood glucose level is more than 200 milligram per deciliter, this is considered to be diagnostic for type 2 diabetes mellitus. So these are the 4 tests that we can use to diagnose diabetes mellitus. Let's proceed to the next. The American Diabetic Association recommends screening for diabetes mellitus for some individuals. From these individuals, we have all adults age 35 years and older. So each individual who is 35 years or older, this is considered to be an indication to screen him for diabetes mellitus. And we have also some specific groups which require investigation or screening for diabetes mellitus. And this includes the patients who are younger than 35 but has risk factors for diabetes mellitus. What are the risk factors? They may be obese, they may have signs and symptoms of diabetes mellitus, they may have a strong family history. Number two, we should screen women who had previous gestational diabetes mellitus. Number three, we should screen pre-diabetic patients. Who are the pre-diabetic patients? They are people who have blood glucose levels in the previous tests less than the values required to diagnose diabetes mellitus, but more than the values which are considered to be in normal individuals. And number four, we can screen children also if they have risk factors. And the most important and the most common risk factor is obesity. Also, it could be associated with hypertension, with a strong family history, with sedentary lifestyles. But as I said, the most important one is obesity. Let's proceed to the next slide. What are the goals of management of diabetes mellitus? We should first control hyperglycemia and
Dr. Esam, I think we lost you. We cannot hear you. Okay, I think Dr. Esam is facing some technical problems. So, Dr.
I am here
Elaf,
now. I am sorry for this, but I had some technical problems. I'm sorry for that. I am here again. Can you hear me?
Yes, we can hear you. Please go ahead.
Okay, I will continue. Sorry for that. So the management goals for type 2 diabetes mellitus, including number one, control of hyperglycemia and its symptoms. Why? Because it is the main thing for type 2 diabetes mellitus. I mean the main symptom, and it is the cause for all complications. Number two, we should evaluate and treat any associated risks for type 2 diabetes mellitus, especially the atherosclerosis and microvascular disease. Number four, we should evaluate and treat any diabetic complications that may occur, which are very common. Number five, we should avoid hypoglycemia, which is either due to excessive medication or excessive physical effort, and it could be lethal within a few minutes. Let's proceed to the next profile. We must consider the life expectancy and the time needed for clinical benefit. Why? Because some clinical trials suggested that some patients may require greater than 8 years to have benefits of glycemic control. Number two, some patients may not be able to have the tight glycemic control for this period, or may be too old and this period will be very long for them. And we have only 2 to 3 years which are required to see benefits from better control of blood pressure and lipids. That's why we should have these factors into consideration when we put the life expectancy and when we put the changes which are required to be practiced by the patient who have diabetes mellitus to control the complications. Let's proceed. The general principles for diabetes management should have a tailored or individualized based on the goals, the values, and the preference of the patient. Why? Because adults who are healthy and functional, they have reduced risks with diabetes mellitus, and they have the ability to treat comorbid conditions. While older adults with intermediate health status, they can participate in management decision, but based on their preference and their available evidences. Why? Because they may be too old, they may not be able to exert all this effort. That's why we should take care of the goals, values, and the preferences of the patient. And the patients who are very old, intensive management is not likely to provide any benefit, and however, it can be harmful. Why? Because it give them the hazard of being exposed to hypoglycemia, which can kill them within a few minutes. Let's proceed. Let's go to the next slide. The interventions of type 2 diabetes mellitus management should include both medications and lifestyle changes. And the lifestyle changes would be the first thing. What is the most important one? It should be weight loss. Why? There is a very direct relationship of obesity and diabetes mellitus. That's why if we encourage the patient to lose some weight, he will improve diabetic control and he will be in the very good weight, which is suitable for his body, which is suitable for his age, and it will help him control the diabetes mellitus. It will help him control the elevated blood pressure, the fat profiles, and all this stuff. Number 2, smoking cessation to reduce the risk of atherosclerosis. Number 3, blood sugar monitoring is something that should be masterized by all patients who have diabetes mellitus. Why? Because it is something that they will continue on for life. That's why they need to be trained over that by their primary healthcare physician. And it could be asked, it could be done through the home glucometer, or it could be done by something which is somehow developed like the sensors which are put under the skin, but they are expensive. Number 4, they should have the appropriate nutrition and they should seek nutrition counseling by a dietitian or something like this. Number 5, they should increase their physical activity and get rid of any sedentary lifestyle. Number 6, they should control their lipids and the blood pressures by taking the medications if they are required to, or do the non-pharmacological measures. Number 7, they should have appropriate eye and foot care because they are very common complications of diabetes mellitus, and we will talk about them further in the next slide. Number 8, they should have education and self-management support for medication adherence, and we will talk about this in the end of this presentation. Let's continue. So older adults with diabetes mellitus should undergo age-appropriate prevention intervention such as influenza and pneumococcal vaccination because they are very susceptible for immunocompromission status and being affected by these conditions. Number 2, they should have careful annual food examination to rule out any diabetic ulcers that they may have because it carries a very high risk for amputation due to low immune system and polymicrobial affection of the ulcers. That's why they should have it yearly. Number 3, they should be screened for kidney disease by doing urine albumin creatinine ratio at the time of diagnosis. I mean for patients who have type 2 diabetes mellitus, and then repeated annually. And if we have an increase, we should interfere immediately to prevent the patient from having diabetic nephropathy, and they should be treated with ACE inhibitors or ARBs. That's why patients who are taking ACE inhibitors or ARBs, no need for them to be continued for screening because they are already on the medications that protect from diabetic nephropathy. Let's proceed to the next slide. The treatment for diabetes patient after doing the non-pharmacological measures that we talked about from in the previous slides includes medications, and these medications includes non-insulin medications and insulin. For the non-insulin medication, we have metformin, which is the first line for treating of type 2 diabetes mellitus. Metformin, which increases glucose sensitization in peripheral tissue and decreases liver glucose production. Sulfonylureases and glenidines are drugs which increases pancreatic secretion of insulin, and both of them has a risk for hypoglycemia and a risk for increased body weight. The thiazolidinediones are also increasing glucose sensitization in peripheral tissue. The GLP-1 receptor agonists increase glucose secretion, and the SGLT2 inhibitors, they prevent glucose reabsorption in the kidney, so they increase glucose secretion in the urine. And the weight loss surgery are given for patients who can't take any medications or insulin can't control them, and they require something emergent to control the symptoms. For the insulin, I didn't talk about it because it is the main treatment for patients who have diabetes mellitus, and we have special slides for them. There are multiple preparations of insulin. Some of them are long acting, some of them are intermediate acting, some of them are short acting, some even are considered to be ultra short acting. And these preparations are used upon the physician preference and according to the case of the patient. Previously, they were like the last line for patients who have diabetes mellitus. Why? Because type 2 diabetes mellitus was treated with other medications other than insulin. But now it can be prescribed earlier based on the treating physician opinion, and he has something or guidelines to give insulin according to the preference of the physician and according to the case of the patient. To the next slide. Then when we consider individualization for glycemic target control, as I said before, older individuals can't get tight glycemic control because it will increase the risk for hypoglycemia, and it will not benefit them. So we should depend on the age of the patient's risk for complications, and the desire of the patient. Why? Because if the patient doesn't have the desire, he will not adhere to the medications that are given to him. That's why these factors should be considered when we prescribe or consider a target for each individual patient. To the next slide. The complications of diabetes mellitus could be acute or chronic. The acute hypoglycemia, which is life-threatening, and we should take care of it because it is extremely important. The hyperglycemic hyperosmolar coma, this occurs due to dehydration in patients who don't take their insulin regimes. Patients who are not adherent to their medical regimes will have the HH coma. This is extremely important. And the chronic complications include macro and microvascular complications. The macrovascular complications include increased risk for stroke, increased risk for CVS diseases, and this stuff, and Dr. Elaf will talk about them. The microvascular complications include neuropathy, nephropathy, retinopathy, and these are extremely important complications, and we should take care of them and screen for each one of them because they are very common in patients who have diabetes mellitus. Let's continue. Let's go to the next slide. So the pharmacological intervention in patients who have hypoglycemia, it should be very extensive because hypoglycemia is considered to be life-threatening. That's why it should be treated very well, especially in patients who take insulin. Older adults are at higher risk of serious this amount of insulin enough, and the longer acting sulfonylureas are more commonly causing hypoglycemia. Why? Because
Dr. Esam, I think we lost you again.
okay, I will continue again. Can you hear me now?
Yes, perfect.
Okay, I will continue. So the sulfonylureases, especially the long-acting, are common cause for hypoglycemia. And the patients who have hypoglycemia and multiple comorbidities or poor functional status, they short-acting to prevent. Let's proceed. Psychological reasons for hypoglycemia should be investigated and treated, and the management plan should be adjusted, and it considered increasing glycemic targets for those with severe frequent hypoglycemia to prevent them from having the complications of hypoglycemia. Let's proceed. Choosing wisely should be, as we talked before, according to the patient target, according to the patient age, according to the patient complication, because severe targets shouldn't be done for patients who are very old, because they are prone more for the complications. And that's why we should weigh the complications and the pros of every medication that we give to the patients. And if the pros or if the pros are more, we should give them. If the contraindications are more, we should change the diet or the treatment diet for someone which is considered to be more beneficial for the patient. Let's proceed. Now I have finished my part, and Dr. Elaf will continue. Thank you.
Dr. Elaf, we cannot hear you.
I'm sorry, Shabab. So, as I said, thank you, Dr. Esam. Now I'll talk about the impact of diabetes on cardiovascular health. Is everything is okay?
Yes, it's okay. Please go ahead.
Yes, okay. So diabetes significantly increases the risk of cardiovascular disease, including coronary artery disease, myocardial infarction, and stroke. The statistic reveals that adults with diabetes are 2 to 4 times more likely to develop cardiovascular disease compared to those without diabetes. The American Heart Association notes that at least 68% of individuals aged 65 or older with diabetes die from some form of heart disease, and 16% die of stroke. So let's have a bit of talk about the pathophysiology of cardiovascular disease. As we all know, atherosclerosis is our first pathophysiology. Diabetes accelerates the form of atherosclerotic plaque, starting from foam cells to fatty streak to formation of atheroma, fibrous plaque, and then plaque rupture and thrombus formation. Second, damaging blood vessels. Chronic hyperglycemia lead to the formation of advanced proteins or lipids that become glycated as a result of exposure to sugar. As is shown in this image, that intercellular formation of AGEs during hyperglycemia enhance glucose flux through glycolysis, induce the generation of superoxide anion by the mitochondria, and the poly-ADP ribose polymerase, which is shown as PARB, that protect DNA from cleavage, induce a post-translational modification of the glyceraldehyde 3-phosphate dehydrogenase, shown as GADPH, impairing glycolysis. This substrate deviation lead to the generation of methyl glycoside that induce the formation of AGEs. Moreover, inflammation, fatty acid, amino acid, and keto body oxidation generate oxaldehyde, including glycoside and glycolaldehyde that promote AGEs generation. Oxidation stress increases by AGEs and by the other biochemical pathways elicited by hyperglycemia, like hexosamine, polyl, and protein kinase. This vicious circle feeds the formation of AGEs and oxidation stress. That's the base of cellular complication in diabetes mellitus. So let's go to the next slide. Third, inflammation. High blood sugar level can promote an inflammatory response, which should contribute to the endothelial dysfunction, thereby promoting plaque formation and increasing the risk of cardiovascular disease. So how we can prevent and manage cardiovascular risk factor? First, counsel the patient regarding blood sugar control, maintaining appropriate weight, increasing physical activity, discontinuing smoking, limiting fat and carbohydrate intake. And consider drug therapy to treat hypertension, prevent MI, like using aspirin, and treat dyslipidemia. How about managing hypertension? The best target blood pressure for all the diabetic patient is unclear. It is important to use a patient-centered approach. But for healthier patients with few comorbidities and functional limitation, target blood pressure of 120 to 140 systolic and 70 to 80 diastolic may be ideal. But we should put in our mind that lowering of blood pressure should be gradually to avoid a complication, as orthostatic hypotension could lead to a fall and potential hip fracture, resulting in functional limitation. Most antihypertensive drug classes have comparable effectiveness, but ACE inhibitor and angiotensin II receptor blocker have cardiovascular and renal benefit for people with diabetes. How to manage dyslipidemia? As we all know, dyslipidemia should be corrected if reasonable, as considering the patient overall health. Measuring lipid panel and ALT within 12 weeks are after initiation of the dose, and increasing of the statin or niacin to assess the adherence and response. Second, routine monitoring of liver function test is unnecessary in patients with statin. More potent statin at higher doses appear to increase the risk of adverse effect. So let's have a small talk about diabetes mellitus and mental health. How diabetes affect mental health? According to the International Diabetes Federation, over 463 million adults are living with diabetes in 2019. And this number is expected to rise to 700 million by the year of 2045. Psychological impact. The lifelong nature of diabetes requires ongoing attention to diet, medication, and lifestyle choices. This relentless need for vigilance can lead to emotional exhaustion and mental fatigue. Daily blood sugar monitoring, fear of complication, the necessity to adhering to a strict treatment regimen contribute to chronic stress and anxiety. Patients also often worry about hypoglycemia or hyperglycemia and the long-term impact of diabetes on their health. Studies have shown that individuals with diabetes are twice as likely to experience depression compared to those without the condition. The burden of managing a chronic illness, coupled with the potential for diabetes-related complications, significantly increase the risk of depression. What is a biological connection? First, chronic inflammation is a common factor for both diabetes and mental health disorder. Second, inflammatory cytokines, which are elevated in both conditions, can affect the brain, leading to mood changes and cognitive decline. Third, fluctuation in blood sugar level can directly impact mental health, mental well-being. As we all know, hyperglycemia and hypoglycemia can both cause symptoms such as irritability, mood swing, fatigue, and cognitive difficulties, further complicating the mental health of the diabetic patient. How we can manage? Psychological support and counseling, incorporating mental health support into diabetes are crucial. Psychological counseling, cognitive behavioral therapy, and support group can help patients manage the emotional burden of diabetes. Also, the role of family, the community support, involving families, friends, and community can provide emotional assistance, practical help with diabetes management, and the sense of belonging. This support can elevate feeling of isolation and stress. Let's have a small talk about the role of genetic in diabetes mellitus. While lifestyle and environmental factors play a critical role in diabetes development, genetics also significantly influence an individual's susceptibility to the disease. Understanding the genetic basis of diabetes can help in early diagnosis, personalized treatment, and prevention strategies. First, we will talk about the genetic factor in type 1 diabetes. Type 1 diabetes is strongly associated with certain genetic markers, particularly within the human leukocyte antigen region on chromosome 6. Specific HLA genotypes such as HLA-D3, DR3, and HLA-DR4 are linking to a higher risk for developing type 1 diabetes. These genes play a role in immune system regulation, which is crucial since type 1 diabetes is an autoimmune disease. Although genetics set the stage for type 1 diabetes, environmental factors such as viral infection, dietary factors, and gut microbiota may trigger the onset of in genetically predisposed individual. The interaction between these environmental triggers and genetic susceptibility is a key area of research. Type 2 diabetes is associated with numerous genetic variants. One of the most well-studied genes is TCF7L2, which affects insulin secretion and glucose production. Other notable genes include FTO, which is linked to obesity, a major risk factor for type 2 diabetes, as Dr. Esam said. Unlike type 1 diabetes, type 2 diabetes is polygenic, meaning it is influenced by multiple genes, each contributing a small risk. The interaction between these genetic factors and lifestyle choices such as diet, physical activity, and weight management play a crucial role in the development and progression of type 2 diabetes. Monogenic diabetes results from mutation in single gene and account for about 1 to 2% of all diabetes cases. MODY is the most common form, with mutation genes like HNF1A, HNF4A, and GCK. These mutations typically lead to impaired insulin production and often misdiagnosed as type 1 and type 2 diabetes. Genetic testing can identify specific mutation responsible for monogenic diabetes, allowing for precise diagnosis and tailored treatment. For instance, some form of MODY can be effectively managed with sulfonylurea rather than insulin. So what's the implication for treatment and prevention? Understanding an individual genetic makeup can inform personalized treatment plans, optimizing medication choices and lifestyle intervention. This approach aims to improve efficacy and reduce adverse effects. Advances in genetic research may lead to gene therapy technique that could correct or compensate for defective genes. While still in the experimental stage, these therapies hold promise for the future management of diabetes. Now we will start to talk about the innovative therapies in diabetes treatment. Diabetes mellitus is typically managed through lifestyle modification, blood glucose monitoring, and medication such as insulin and oral hypoglycemic. Despite these options, many patients struggle to achieve optimal glucose control, necessitating the development of new treatment. The limitation of current therapies highlight the need for innovative treatment that can offer better glycemic control, reduce complication, and improve quality of life for diabetic patients. Advancements in technology, pharmacology, and biotechnology are paving the way for these novel therapies. First, we will start about technological advances. Continuous glucose monitoring system provide a real-time data on glucose levels, allowing for better glucose management by alerting patients to hypo and hyperglycemia. These devices have significantly improved diabetes management by enabling timely intervention and adjustment treatment. Also, insulin pump and closed-loop system, which is known as artificial pancreas. Insulin pumps deliver the continuous subcutaneous insulin, mimicking the body's natural insulin release. Closed-loop system combine with insulin pump to automate insulin delivery based on glucose reading, offering a more precise and responsive approach to glucose control. The pharmacological innovation, like GLP-1 agonist, these drugs mimic the action of the glucagon-like peptide, enhancing insulin secretion, suppressing glucagon release, and slowing gastric emptying. Example like liraglutide and semaglutide, which also promote weight loss. SGLT2 inhibitor, which is known as sodium glucose cotransporter 2 inhibitor, reduced glucose reabsorption in the kidney, leading to increased glucose excretion and lower blood sugar level. Drugs like empagliflozin and dapagliflozin have shown additional benefit in reducing cardiovascular risk. There is advances in insulin formulation, the development of ultra-rapid-acting insulin and long-acting insulin provide more flexible and effective option for managing blood glucose level, improving both postprandial and basal insulin coverage. Also, there is stem cell therapy and beta cell regeneration. Researchers into stem cell therapy aim to regenerate or replace the insulin-producing beta cells in the pancreas. Techniques such as using pluripotent stem cells to create functional beta cells offer the potential for a long-term solution to insulin deficiency. There is gene editing technologies like CRISPR and other gene editing technologies hold promise for correcting genetic mutation that cause diabetes. How? By targeting and modifying specific genes. These technologies could potentially cure monogenic forms of diabetes and improve beta cell formation in other types. Also, there is other way we can use as a mobile health app and telemedicine. Mobile health apps provide tools for tracking blood glucose levels, diet, and physical activity, facilitating better self-management of diabetes. Telemedicine offers remote access to healthcare professionals, making diabetes care more accessible and convenient, especially for those in remote areas. Digital tools enhance patient engagement and adherence to treatment plans by providing personalized feedback, reminder, and education. They also enable data sharing with healthcare providers, allowing for more informed and timely clinical decisions. Last but not least, we will talk about diabetes education. Lifestyle modifications that focus on diet, exercise, and weight loss can delay or prevent the prognosis of diabetes in people with impaired glucose tolerance at higher risk of developing type 2 diabetes. If the patient is clinically complex, consider referral to a diabetes educator, disease management program, or especially physician care. What's the core component of diabetes education? First, nature of the diabetes, its type, and the potential complication. Second, hyperglycemia, precipitating factor, prevention, symptoms, how to monitor, treatment, when to notify the physician. Third, blood glucose self-monitoring when appropriate. 4, diet and physical activity. 5, medications, purpose of the drug, how to take it, common side effect, important adverse reactions. 6, food care. So we will have small cases. A 56-year-old woman come to the office for the welcome to Medicare preventive visit. She uses a 4-wheel walker to assist with ambulation. About the history, she have diabetes mellitus, diagnosed 3 years ago, hypertension, osteoarthritis of the knee and hip. Regarding her medication, acetaminophen, 1,000 milligram, 3 times daily. Tramadol, 50 milligram, 3 times daily, as needed. Metformin, 1,000 milligram, twice daily, and lisinopril, 40 milligram per deciliter. In examination, we found that her BMI is 30 kilogram per meter, unremarkable cardiovascular and pulmonary finding, bilateral knee crepitus with extension, with no focal pain. With the walker, gait is stable but slightly wide-based, with decrease in the knee flexion. Hemoglobin A1C was 8.5%. Which one of the following is the most appropriate recommendation? A, weight loss to achieve normal BMI. B, diabetes self-management education program. C, prescription of glipizide. D. Exercise prescription for walking 150 minutes per week at moderate intensity. I will give you 1 minute to answer. So the answer is B, Diabetes Self-Management Education Program. The second case, an 80-year-old man come to the office with his son, who is concerned about his father's memory. The patient wife died 9 months ago. He says he feels lonely at times but not depressed. The son notes that his father was gotten lost a few times when driving to church, and there are unpaid bills lying around the house. About his history, type 2 diabetes, diagnosed 20 years ago, mild knee osteoarthritis, well-controlled hypertension. Her medication was aspirin, losartan, hydrochlorothiazide, metformin, insulin, glargine, insulin lispro. According to his chart, the prescriptions expired 2 months ago, and he missed his last 2 appointments. Regarding laboratory finding 1 year ago, normal electrolyte levels, normal renal function, hemoglobin A1C of 7. Today, her hemoglobin A1C was 9.5 and normal thyroxine level, thyrotroponin levels was 8. Which one of the following is true about this patient memory change? 1. His executive dysfunction is unlikely to be related to his diabetes. B. Hyperglycemia is likely impairing his cognition. C. Correcting his hypothyroidism will likely improve his condition. D. Tight glycemic control will likely improve his condition. For the sake of the time, the answer will be hyperglycemia is likely impaired in his cognition. Thank you, everyone.
Thank you, Dr. Elaf and Dr. Esam, for this very informative presentation. And now we will proceed with the second presentation that will be delivered by Dr. Leem. Dr. Leem, please.
Hello, Elaf, if you could make, Dr. Nader, if you could make me the host now.
Okay.
Hello, everyone. My name's Leem. Can everyone hear me?
Yes, we can hear you. Please proceed.
Okay. My name's Leem Ismail. I'm going to teach you guys how to create a graph on Canva today. So Canva is a tool online for graphic design, and it's free for the most part. There's just some paywalls for premium. So in order to create an account, I create an account first, and then I select create a design. I selected presentation because that was the most suitable for me today. And then afterwards, you just select your page. This is your toolbar on your left side here. You go to elements, and then you search in the kind of element you'd like, graph or chart, and then you just select the chart you want to add in. So that's the first part. If you want to delete it, you delete it that way. So when you get to the actual chart, you can either create a table on Canva itself. So I filled it in with the labels I'd like and what I'd want the values to be. And then it translates over to the chart directly. Okay. And then the other option is you can just connect it to your Google Sheets. So you select, since I'm already logged in through my Google account, I can select the sheet that I have already. And then I select the range of values or which cells I want the values to come from. And since my sheet is right here, I want the values from A2 to B6. So I'll put that here, A2 to B6. And I update, and then the values of the chart will change. So it's basically that simple. And you can change the colors up here. You can change how you want it to look. So you can have it show the numbers or the percentages. You can show the legend, or you can choose not to show it. You can add some text and headings on the side if you'd like. And it's basically that simple. The other kind of chart is the demographic chart. This is a bit different. So first of all, you can add a percentage label or get rid of it. You can mess with the appearance of the actual chart. And then you modify the percentages by typing it in through here or shifting it like this. And that's basically all. I encourage everyone to try to use Canva for their own presentations because it makes the progress much, much easier. And does anyone have any questions? So that's it for me, and I'm going to hand the stage over to Gayatri, and she's going to present the next topic.
Am I audible? Hello, everyone.
Yes, Gayatri, we can hear you. Please go ahead.
That's okay. Is okay. Give me a second. Okay. Hello, everyone. I'm Dr. Gayatri, and little introduction about myself. I am a IMG from India, a medical graduate. I'm going to apply for internal medicine residency this year. So today's topic is focus group research. So I'm just gonna take a moment and shift this to. Okay, so what are focus groups? Focus groups are small group discussion, like planned small group discussions consisting of a moderator and few participants. So the participants should ideally be around 6 to 10, so it won't create any overcrowding, or you'll have difference of opinions, and it just be like 6 to 10 is considered as a good amount of people in a focus group, and they are highly participatory, can be used to obtain diverse ideas and perceptions about selected topic. And a focus group also have a moderator that leads the discussion by asking participants to respond to open-ended questions. So this is how a focus group can be. It can be in any setting where people come together and discuss on a topic, and you from there you get a qualitative data that you can use for your research purposes. So uses of focus groups. First of all, first thing that you need is of idea generation, stimulation of brainstorming, then session to generate new ideas, concepts, and solutions, participant interaction and planning, data collection. So in data collection, you gather a qualitative data through interactive sessions and group dynamics. You also get in-depth insights about a topic. You get deeper understanding of participants' perspective about that particular topic, and flexibility, very important, allowing to be flexible in research design and adapting to the based on participants' feedbacks, their perspectives, if they have any new ideas about it. Next is, what are the benefits? So different experiences, ideas, and views often emerge in very short time, and that allows participants to form new perspectives, insights from the discussion with other groups, other focus group participants. Sharing and comparing is very helpful when they share their perspectives, their ideas, and then you can just compare your views or other participants' views all together to make a proper qualitative data to the particular topic, and revealing how people talk. Very important point, you will get the better idea of understanding about a topic, how people think about this topic, and what are their perspectives or their ideas, how you can make that particular thing better, and exploring potentially sensitive topics. Considerations before starting a focus group. So you need informed consent from the all participants. You have to explain the purpose of your project, how the data will be used, what are you looking for in this project, and confidentiality, time management like there are different time management expectations from participants that they have to fulfill. Some participants like do some participants do have they promise more and they cannot fulfill at that time, so you have to be very clear while forming a focus group about. And when should you avoid a focus group? So participant cannot fulfill the ideal requirements if giving assurances that you cannot fulfill in time, and participants are not comfortable with each other on a particular topic, or maybe because of a different cultural differences. So you have to be very clear while participating in a focus group. So types of focus, there are different types of focus groups. So single focus group, this is very classical type where you have participants placed in a one group and they have interactive discussions about a topic. And there is a two-way focus groups. This format involves using two groups. So one group actively discusses the topic and the other group just observes that um, like who is okay, sorry. One group actively discusses the topic and the other group observes the first group and then discusses their interaction. And this can happen vice versa when the other group becomes observer and the one group becomes a discusser group. Then next one is a dual moderator focus group. The moderators work together with one moderator asking the questions, leading the session, and the other moderator ensuring that all questions are asked and any new evolutions are discussed further. So how do you form a focus group? First of all, you need a planning. You should have a proper research design. Then recruiting the ideal participants. Participants can have different characteristics. For example, they can be strangers, acquaintances. They may be homogeneity, or they may follow like it depends also on if you only want females or males, experts or knives. So you can have different kind of participants for a particular research design. Then moderating, you need to have a moderator who will lead the project, analyzing and reporting. So structuring a discussion. So to start a discussion, you should have a clear idea about what you're going to include in it. So number of questions, ideal number of questions are considered as around 5 to 7. So you can discuss those questions and form a data. And then, so that will definitely help you to give a good data to analyze it in the future. Sequence of questions should be opening questions. There will be introductory, transitioning, and key questions to the particular topic. Then item writing should be, so when you are writing about it, then the item writing should be conversational, very clear in a simple language where everyone will understand it, and it should be open-ended. So in discussions also, you have to be very aware of the participants' limits, like the attention, time, language, cultural issues, communicational skills of different participants. Next, what's a moderator? So moderator should be having strong interviewing technique. He should be like keen observational skills, ability to control and guide the discussion, and moderator should have ability to suppress own personal views. So the person like whoever is a moderator, he should be very neutral with his thoughts and respect for participants. So active listening, eye contact, concern for comfort is very important skill to have in a moderator. So they have just given characteristics of like listening, language and communication, using feedbacks, conflict handling, questioning, having neutral, not having ego regarding a particular issue. So analysis of focus group data. So I just want to give you what type of questions you can go for when you're. I'm just going to give you an example so of a focus group. So if you have formed a focus group regarding a community, the people of participants had a history of malaria within 5 years or something, then they have been started on a new drug which is a new drug for malaria. Then in that focus group, you can just ask them, please share your own experience with that particular tablet. Did you have any problems taking the tablets? Did you experience any side effects? So if the tablet is given to children, so where you be comfortable giving the tablets to the children? So what were the reasons that made you take the full medication regimen? Would you participate in this intervention again or not? So if not, then why not? So these are the questions, and you can ask in a focus group related to a particular research topic. So you'll have a qualitative data, and that data can be analyzed on the basis of different analysis like content, thematic, and grounded theory analysis. So content analysis is a research tool used to determine the presence of certain words, themes, or concepts within some given qualitative data. Thematic is focuses identifying and understanding the major themes and their relationships within the qualitative data. And grounded theory analysis is used to develop theories or conceptual frameworks based on the collective data. So on the basis of these analysis, you can form a like qualitative data that, and it can also be like that when you have a one focus group which has 5 to 10 participants. You can also have the same related topic. You can have different focus groups, and you can just collect the whole data from different groups and make analysis out of it. So that's all about focus groups. Do you guys have any question?
Thank you so much. This great presentation, and the previous one also was a great one. Thank you for sharing.
Thank you, Dr. Nadir.
And I want just to share with you my experience with writing a paper regarding thematic approach. So we did publish a paper that was in 2020, and that's regarding the use of technology in older population. So what we did, it's my colleague idea to address this and see if we can come up with what older people think about technology in general and how they use it, so that if we want to develop something, we can incorporate their perspective or their look at when we develop something for them. So basically, in a small short description, what we did, we approached a group in an assisted living facility, And then we approach a different group here in Michigan, in Lansing, Michigan State University. So the first group were mostly retired or semi-retired, older adults. And the second group in the university, they're still working. So maybe in their 50s, compared to the other group, maybe in their 70s or 80s. And as mentioned here, the group were got together, and a moderator was asking the questions or leading them to discussion. And then we recorded what they told us at that time, both group. And then when we did the analysis, we looked at what they said and put them into an Excel sheet and tried to divide them into themes, common themes. And to get to these themes, we can understand, for example, their why they are afraid of using technology. Is it security concerns? Is it the technology itself? They don't know. Is it the health issue? They have arthritis. They can type. They can use the font, the small fonts. Is it the vision? So we put it into themes and then analyzed these themes. And then we wrote the paper. We submitted. We got some feedback. We submitted again. And finally, it got accepted and published. So it's an easier way of doing some publications. It may take some time to plan ahead, but the idea could be the same. So for example, nowadays is artificial intelligence. Just I'm thinking with you, we can create or establish a study about the perception of the use of artificial intelligence in health care system, for example, or in general by international medical graduates or dental graduates or whatever group that you think about. And then we can invite some of these fellows in this program, or maybe each one of you in their countries. Let's say you are in India or someone in Pakistan, in Saudi Arabia. Someone can gather a group of international medical graduates who are planning or who got step 1 or step 2 or step 3 or planning to come to the US. So in this group, how many? Let's say 15 or 10 in Saudi Arabia, 15, 10 in UAE and India. So each group, they can discuss certain questions, as she mentioned, like 5 questions, and see what the perspective of each group, and put this together, and then we can analyze that. Maybe a group here in the US can do that, or in England can do that, or collectively we can do it in different places and then collect all the information. And this can be done easily. You can ask about what tools, like, is it ChatGPT, is it Bard, Gemini, is it Microsoft artificial intelligence, and how you use that in your practice, in your preparation for the ERAS application, in other aspects. So 4 or 5 questions, and then we can collect the information about that and see if we can come up with some themes. And then you can publish it in a format of a poster in a conference, or maybe you can go all the way to write a paper, something like that. But thank you so much for a great presentation. Dr. Elaf.
Thank you so much, Dr. Nadir. It was really great idea that forming focus groups, and we can definitely collect the qualitative data regarding at least regarding the application and how you study for steps and everything. Yeah, it's a really good idea. Thank you so much, Dr. Nadir.
You're welcome. Thank you.
Thank you, Dr. Nadir and Gayatri. Now it is my turn to present my topic. Dr. Nader, if you can please assign me as host so I can share my screen.
Go ahead.
Thank you. Okay. I don't know. Can you see my screen?
Yes.
Okay, thank you. All right. So today I'm going to talk about SPSS, and it will be a general idea on how to get the software, how to download it, and to use it. So hopefully by the end of this presentation, we will have some basic information about it. And after we install it, how we're going to navigate the interface and how to enter the data or import it from different files. And we will also have a practical part where we will be performing some basic analyses and data visualization. So starting with an introduction to what is SPSS, it is short for Statistical Package for Social Sciences. This is how it was originally developed, but now it stands for Statistical Product and Service Solutions. It's also known as Predictive Analytics Software. Anyway, all these names point to a very powerful software that is used to analyze and interpret the data. It provides a very wide range of statistical procedures, ranging from simple descriptive statistic to a very complex multivariate analysis. So it is used for processing questionnaires that we develop for research. We use it to report data in forms of tables or graphs, and it also analyzes measures such as means, chi-squares, regressions that we can use to establish relations in our studies. So SPSS was introduced back in 1968, but in the year 2009, it was acquired by the technology shark IBM. So now it's officially known as IBM SPSS. What makes it accessible to both the beginners and also the experienced user is that it has a very user-friendly interface. It has intuitive designs that allow the user to easily navigate it, to check the menus, to perform the analyses, and also to interpret the results that come up. So in the data management domain, we can organize, clean, transform the data, and also not only to manually enter it, but we can import it from different sources, such as Microsoft Excel or SAS. And because of its high reputation and reliability and accuracy, it is a trusted tool for data-driven decision in many governmental, non-governmental institutions, in research, and different industries, even retail industries. It is used to make data-driven decisions on the product lines they're developing, the customer preference, and many more things. So here are just examples of the basic operations that can be run in the SPSS. We can manage the variable by entering them, adding or deleting them. We can enter whole data sets and manage them. We can save it or import it from different files that are not SPSS files. We can sort the data in different categories and also transform it to charts or visual images. Okay, so now how do we get the SPSS and how do we install it into our systems? So there are many sources, but the main ones are the IBM SPSS website, where you go to their main website and you download it directly from the platform. You will need to create an account. It is called IBM ID. You registered with your email, preferably if you have an institution email, an academia or work email, but you can also use your regular personal emails. The second option is you can get it through your academic institutions, and usually this is a free option for students. So you, if you are in a university, you would go to your student centers and they will help you download it into your system. Also, there's an app on the Google Play for Android systems where you can download it to your phone and use it. So after we download it, we'll take the example that we downloaded from the website. So when we access the SPSS website at the IBM, we will have a variety of options to download. So we have to choose the right version, and we have to consider the operating system. Are we using Mac or Windows? And also the features that we need. It is easy to download it because you have all the steps in a user-friendly interface. And when you download the software, a dialog box pop up and leads you to the steps that you can install it, and you choose the file where you want to keep it on your computer. After the installation is complete, it will ask you to activate the license through the IBM ID that you created before downloading. But the good thing is you can have a free trial. It's a 30-day trial, and this is what I did for the purpose of the presentation because I don't have SPSS. So you can download the trial and try to work the software. It gives you access to almost all the features that you need, and then you can decide if it's a good program for you or if it satisfies the needs that you need. Okay, so after we download it and install it, and we open the SPSS, this is the first thing that we're going to see. It's this dialog box. So you have the option to not show this again in the future, but I choose to show it because if you look up here, I don't know if you can see the cursor, it gives you the option to open new files where you can get new data sets. And if you look below that, it gives you the option to open recent files. So if you have been working on some multiple files, you can easily open them. You don't have to browse on your computer. And it also provides some sample sets if you want to try to do some sort of analysis. It can provide some free sets for you to use. Okay, so when we open the interface, we will notice that it's composed of three main parts. The first one is the menu bar, which is on the top, and it includes the data manipulation and analysis and file management options. We will look into a screenshot, and you will notice that it is similar to the Microsoft Office Suite interface. Below the menu bar is the toolbar. It also has options for each of the menu bar option. You will have a toolbar under it. I will show you in a minute how that looks. And the third component is the data editor. The data editor is like a spreadsheet, like the Excel spreadsheet environment, and it has different windows. So this is what we will see when we open the SPSS. On top, the menu bar where you see there's File, Edit, View, Data. Below it is the toolbar, which is quicker way. For example, let's say if you want to save a file, you don't have to go to the menu bar to choose File and then Save or Save As. You can just go to the toolbars and click on the Save icon and make it quicker. And this is the data editor part at the bottom. These are the most common used windows, the data view and the variable view. So like I said, there are different types of windows. We have data view, variable view, output, syntax, and chart. The ones in green are the most commonly used while doing the analyses, and the ones in yellow are least used. I shouldn't say least used, but the use will depend on the research that you're doing and the information that you're trying to obtain. So if you click on the data view, you'll see the spreadsheet, but you'll notice that the column on the left represent the number of respondents or the questionnaires. So here we will see the data that you put, the data set, and you'll be able to enter it, edit it, or display it. If you click on the second window, or the variable window, it will show you information about the variables, not the whole data set. So here will be the place where you can identify and manage the variables themselves, define them, and adjust them. Okay, this is an example of an output window. This is what we get when we run any analysis. This window will pop up. For example, if we run frequency, it will come as descriptive statistic. For example, if we have a gender variable, it will show us the frequency of female, male. So I just wanted to show you the window here, but we will come to the practical part. And also, this is the chart editor. If you develop a chart, it will come in this window. And from here, you can edit it, you can copy it or save it. Okay, and the syntax window is usually used to enter the SPSS language. And this is usually used by the programmers, not by the regular users. Okay. So now let's talk about how we enter or import data into the SPSS. But before that, we need to have a common ground understanding on some concepts. First thing is the variables. So what are the variables? These are concepts that can take different values. It can be quantitative or qualitative values. For example, if you are considering buying a second-hand bike or a car, what are the variables that you will consider? Let's say you will think about the brand, the type of the bike or the car. You will consider the appropriate car for your age. Do you want a good car, excellent or poor condition? And also you'll consider the price. So these factors that you are considering are called variables. So generally, the variables are divided into dichotomous, which give two values, either yes or no, or male or female. They're just two options, or continuous variables. These take values within either a given range or infinite set, like income, age, test score, or lab test score. Okay. Also, we need to understand the concept of measurement scale. This is a scale for the variable itself. So the scale is divided either to nominal, ordinal, or interval or ratio. What do we mean by that? The nominal, for example, if the variable is a nationality, then the scale for this variable will be based on the concept of having different categories, but they don't necessarily have to be in relation to each other. A nationality, someone can be from the US, someone from Mexico, someone from Sudan. So this is a nominal scale for the nationality variable. On the other hand, if we talk about the ordinal scale, it is also for categories, but in this case, the categories are in a rank order. For example, one category is more than the other, or one category is highest to lowest. For example, the level of education. We know that primary education in school is lower than secondary education, and high school is lower than master's degree. So this scale is the ordinal scale for this variable. We also have the interval or ratio, which are grouped together in SPSS. And here, for example, if we are talking about income, then we will have the scale of a ratio. For example, how much of the income is spent on certain medical treatment, or how much of the income is spent on housing. So the scale here will be ratio. In this slide, I'm just trying to elaborate more on the scale. So if we look at the nominal scale, and we have these three individuals competing in a race. So giving them numbers or assigning them ID, it has nothing to do with their finishing the race. So this will be just a nominal scale. But if we go to the second row, where we see that when they finish the race, there's a first place, second place, third place, then here there's a rank order. So this scale will be ordinal. Okay, I hope it's clear, the difference between them, and also the ratio and the interval. Okay, so in SPSS, when you enter the variable, it will default the scale to interval or ratio. That's why you have to check the type of variable and make sure the scale is set correctly, according to what do you have in your questionnaire or what do you want in your data set. So now we'll talk about manually entering the data. This is the theory part. So you will start with the data editor, which we already established that it has two views, the data view or variable view. You can use either of them. And then you will start manually putting your data. So it looks like an Excel sheet, and you can just click on the cell that you want to put the information in. So in this screenshot, we see that we're talking about the data view, and here we are able to see the whole data set. It includes different variables, the ID, the gender, the date of birth, and here we have the data sets. These are the data for the date of birth, data for the education, and the job category. If we click the other window for the variable view, we'll see that this view is only talking about the variables. So here we do not see the data, we only see the variable. This is the variable of the gender, this is the variable of the date of birth. So if we look at the second row where it says gender, we'll see that we have to put in the type of this variable. I'm sorry, we'll start with the name of the variable. You have to assign the type and the width, the decimal, the label. What do these columns mean? The first one, name, it's the name that you give to your variable. So this column, it must be in alphabet letters. It cannot be numeric, and it must be unique to the variable because you don't want to confuse yourself between the different variables. The SPSS rule gives you a space of 64 characters, but it has to, so the name has to be less than that. It cannot be a longer name. Spaces are not allowed. However, if you need to divide words, you can use underscores. The second column is the type, and here you're going to assign the type for the variable. So in SPSS, the most commonly used one are either numeric or string. So numeric, if your variable will take a number like age or height, so you'll put a numeric type. But if it will take a text type, like you are talking about, you're assigning, for example, a state for the individual, and you're going to write the name of the state. You're going to put it in text, so you will choose string. So string means non-numeric values. Okay. This column is the width. It will allow you to determine the number of characters. Do you want it wide or do you want it narrow? The decimal column, if you are assigning a numeric variable, for example, the height, and you need to put some decimals, so you will put here the number of decimal that you want the SPSS to allow. For example, you want 0.5 or 0.563 or So, but it has to be less than or equal to 16. So it cannot be infinite number. The label is how you describe your variable. So the variable has already been given a name, but you still need to have a description. For example, if we labeled a variable name, in the label, you're going to say name of who? Is it the name of the participant? Is it the name of the place where the participant resides now? So you have to specify the description of the variable. Okay. In the value, here it's mostly for the variables that are categorized into more than one category. For example, the male or female, or the questions with yes or no. So you will have a value that you will assign. For example, if we want to put 1 for male and 2 for females, you will open in that cell and you put the value number and the label, and you will enter it so that SPSS can record whatever data you put as male as 1 and whatever data you put for female as 2. When you're done with entering your data, you can save it just like you're saving a Word document on Microsoft. You will go to File, and then you will choose the type of file to save it as, and the destination where you want the folder to be. And like we said earlier, you can also use a quick access from the toolbar where you can just click the save icon. All right, so now we'll talk about the basic analyses. These are example of the most commonly or used analyses. For example, the frequencies. These produce frequency tables that show you, for example, the counts, how many people in your samples, what are the percentages of the males to females, or percentages of income to diabetes medication. So just to have frequencies or information about your sample. Also, descriptive analysis. Here you can use it to describe your sample for giving mean, standard deviation for the different variables, assigning maximum or minimum value for each variable. So here we're just describing what's going on with your sample. We're not trying to establish any relations or any conclusions of the study. Also, we can, as basic functions of SPSS, we can use the data sets to produce graphs and charts to describe the information in a visually pleasing and quickly to catch by the eye. Great. So here's also a theoretical example of how to open the data set. This is the window for the SPSS. You'll go to your file. You'll go down into the toolbar, choose Open, Data, and then the window will come up for you to use the set that you want, and you will import it. How you run the analysis, for example, the frequency analysis. All the analysis, you will go in the Analyze icon in the menu bar, and then you'll go down to choose the type of analysis you want. If we want to run frequencies, it's a sort of descriptive statistic. So we'll go to descriptive statistic and choose frequencies. You'll click it, okay it. It can also give you option because it has different types of statistics. So you don't have to get all the types that or all the options there. You can choose whatever suits your needs for your study. For example, you just want to see the mean or the standard deviation, or you just want a pie chart. So you choose whatever you want and you okay it. So on the left side, this is how the frequency table comes up in the output window. And on the right side, this is an example of the data visualization. Both of these, you will not see them on the data view or the variable view. You will see them in the output view. Okay. And likewise, if you want to run descriptive analysis, also you will go to the Analyze icon in the menu bar. You will go down to Descriptive Analyses. You will choose Descriptives, hence the name. And then when the box is open, you choose the variables that you want and the measures that you want. So really, it's user-friendly. You just click the desired options, and once you click them, the output window will automatically pop up. So you don't have to open it from somewhere. It comes to describe your data set, tell you what is the minimum, the maximum, what is the mean for each of the variables that you chose. For example, if you chose educational level, it will tell you that this is the mean, or the salary, this is the mean of the salary of the individuals in your sample, this is the maximum, this is the minimum. Okay, so now moving on to a practical part. Like I mentioned earlier, I've downloaded the SPSS trial version, and we'll open it now. I hope you can see it on my screen. It's pinned in my taskbar, so I clicked it, and it's opening now. I have the version 29. And I'm using Windows system. Bear in mind that
I think we're still on the view for the PowerPoint. So can you unshare your screen and then share it again?
All right. Okay. Thank you. Let me
Thank
try
you.
that. Wait. Are you able to see it now? Can you see my screen now?
Yes.
Yes.
So what I did is I opened the SPSS program, and this is the dialog box that I told you that you have the option to not show it again or show it. Here you can choose new data set, or you can choose sample files to run your analysis if you want to practice. You can go here to see if you have any recent files. So I didn't use the SPSS, but typically I would have them here and just click them. So let's try the new data set. You can either double click on new data set, or you can just highlight it and go down and click open. Can you see the screen?
Not anymore.
No.
Okay, I'm sorry, I don't know what happened. Let me try again. Okay, how about now?
Yes.
Yes.
Okay. All right. I'm sorry. It seems that if I open another
What you can do, you can unshare the screen, and when you go back to share the screen, there is option to share the whole window, not only one tab or one program.
Okay. So entire screen. Okay. So do you see the presentation slide?
Yes.
Okay, good. And now this is the new data set. So I opened a new data set on the IB and the SPSS, and now we'll try to practice entering data manually. So if you look at this table, we have a small data set that we're trying to put in. I'll just try to put it on the side. Hopefully you can go. So I went to the variable view, and I want to put the first variable. The first variable is name. So in the variable view, we will enter stuff horizontally. So the first variable is name. And once you put it in, SPSS will automatically populate the other cells, but you still have to see if it's the right way. So remember, we talked about name. Here we're going to put the names of the participants. So the type of the variable is not numeric. So we want to change that. So I clicked on these three little dots on the square on the cell itself. This variable type window popped up, and then I will choose string, because remember, string is the type of variable that is non-numeric. So the type can be numeric, it can be currency, it can be date or anything. But now, because for the names, I'm going to free text them or write them alphabetically, I'm going to use string and okay that. The width, this is the width of the column. I'm not going to change it. Decimals, I don't need to add them because I'm going to write alphabet. For the label, I'm going to put the label for this variable, which is the name. So here, this is going to be the name of students or participants or whatever the description is. I will not put values because it will be different for everybody. It's not like I have a certain category. I'm not addressing any missing values here. For example, if I want to take out certain names, I'm going to put them here, so the SPSS will not consider them. And also the number of columns is 8. We don't need to change that. A line is just how the cell will look. Do you want the writing to be to the left, to the right, or the center? And the measure is the scale that we talked about. Remember the three types: the nominal, the ordinal, or the ratio or scale. So because string is it's a category, it's either ordinal or nominal. But because names don't have rank order, so there's no name more than another name or lower, so it will just be nominal measure. Okay, I hope this is clear. We'll try another example for the age variable, the variable number 2. So here I'm going to write age, and the type of variable, so I'm putting age as number of years, so it's going to be numeric. Don't need to change the width. And because in age, I'm going to put the number in years. I'm not going to put it like this person is 23 years and 3 months. So do you understand the idea? I don't need to put decimals, so I can put them as 0. Label is the variable is description of the age of participant or student according to your questionnaire. I don't need to put values because it will be depending on the age of the participant. No missing values here. For the scale, can you guys write on the chart, I'm sorry, on the chat, what do you think the measurement scale should be for the age variable? Is it ordinal, nominal, or scale? Okay, so for the time's sake, we'll do it as scale. Scale is for continuous data because we have numbers. Okay, so this is the idea. In the variable view, you will put each variable, you will identify it by putting it in its type, label. I'll just add another one just to demonstrate the value part. We'll put the gender. Okay, so gender, it can either be a string where I'm going to put the data as male or female, or I can put it as numeric and add values. So what do I mean with that? I mean that I can put label as gender of participant. And then the value cell, I will go to the 3 little dots and add value. So the value is, let's say that we're going to put number 1 for male. Okay, and then add, we'll click the cross or the plus sign. And then we'll put the second value. For example, number 2 means female. Okay, so, and okay. In this way, when I enter the in the data view for each participant, I don't have to free text male, female, male, female. I just put 1, 2, 1, 2, 1, 2. Okay. And here, this is a nominal scale. All right. I hope the idea is clear. Now moving to the second part of the practice. Here, I wanted to show you how you guys can import sample data set or from another file, and how we can run simple descriptive analyses. So I already have this Excel file for practice here. I just wanted to show it to you. It has variables and some data. Okay, so what we're going to do is, when you go to the SPSS, you will go to File. You will, I don't want to import data to this data set, so I just opened a new window for the data. And then I will import data, for example, from Excel. I have an Excel sheet or Excel file on the desktop. So I'll just choose it, click open. Okay, this is the preview, how it looks. And then see, SPSS imported the data from the Excel and displayed it on the SPSS itself. So this is the data that we had. The table had the name, age, and it automatically adjusted the variables. But you still have to go to each variable and make sure that SPSS did the job correctly. For example, the name, string, it's nominal. The age, numeric, scale, that's good. Gender is nominal. Height is scale. But height, for example, when I look into the data, the height is 5.3, 5.7. So I need some decimal. So I will put some decimal for the height. Okay. The education level, if we look at the data set, we have different educational levels and they are ranked because we know that high school is lower than university and postgrad is higher than university. So we need to make sure that for the education variable, the scale is ordinal scale. Okay. All right. So this is how we imported a data set. And if you remember when I opened the SPSS and I had the big dialog box, it had samples for data for you to practice. So you can also open it from that folder. All right, so now let's try to run some simple statistics. Okay, so if you remember, when we want to analyze anything, we will go to the menu bar, choose Analyze, and then for simple statistic, we will go to Descriptive Statistics, Frequencies. Then you will choose the variable that you want to run the frequency for. For example, if you want to see the gender, the height, and education. So whatever variable you want, you will highlight it, and then you will move it to the variable space here. If you don't want it, you can move it back by clicking the arrow here to take it back. Okay, and then you choose OK. You have the option to choose the statistics or the charts, but let's start with simple frequency tables. So once I click OK, you see this is the output window. It just pulled up automatically to show me the frequency of the variables I chose. For example, I chose the gender. So it's telling me that in my sample, I have males, their percent is 25% of the sample. I have 3 males. This is the total. This is the description for the height, and so forth. Okay, and let's, so you see when I wanted to close it, it gives me the option to save it or not. I don't want to save this one. Let's try to run something else. We'll go to Analyze, Descriptive Statistic. Here, let's go to Descriptive. For example, I want to see the height variable. I'll move it to the variable space. And here, let me see the options. Here are the options that SPSS gives me. I don't have to choose all of them, and some of them are preset. But for example, I want the mean, the standard deviation. I want to see the minimum and maximum height. I want to see the range, for example, the skewness. So it really depends on what you want from the study, or what are the results that you're aiming to see. You will continue. It will take you back to your variable in the descriptive window. After you made sure that you have the right variable and the statistics that you want, you will OK it. And then the output window will pop up to show you the height variable that you chose. This is how it ranged. The shortest person is 5.3. The tallest is 6.1. The mean of the height is this number, and this is the standard deviation. Okay, again, you can save this file, or you can delete it. I don't want to save it now. Let's try to run some visuals. For example, let's do a graph or chart. So we'll go to Graphs, and we'll go to Chart Builder. Okay, it's just telling you to make sure that your measurements are okay. They're defined. And here also you will choose the variable that you want. For example, we want to see the age. And let's see, we want to see a bar chart. So you double click it. This is the preview, and it's asking you about the x-axis and y-axis. What variables do you want? So what you do is you highlight the variable and then you drag it. So for example, I want to see only the age variable. So I will drag it down the x-axis. And okay, so let's see the histogram. Let's OK that. Okay, yes. So the pop-up, the output window will give me a simple bar of age. Here I can see the frequency of the x-axis, I have the age groups, and then here the frequency. I have 2 people who are in this age group. I have 1 person in the 20 years. I have 1 person in the 25, so forth. Okay, and the last analysis or graph, let's see if we can build something else. Let's see for gender, for example, let's see if we can do a pie chart. So we'll click it and see it's asking you, what do you want to slice it by? I will drag the gender here, and it automatically puts the count. If you don't put another variable, it will put you. So you have the option of putting more than 1 variable, but for the sake of explaining this, I'll just make it simple. We okay it, and then we'll have our pie chart where it tells us the female and male, and we can also play around here by putting the percentage or changing the color or the shape of the chart. All right, so we're done with the second practice. So I'm back to the objectives because I came to the end of my presentation, and I hope that you guys had a good idea about what is SPSS, how you can download it and install it, how you can navigate the interface, and what do you expect to see. You have an initial idea of how you can manually enter data, how you can import it from a different file like Excel file, for example, or SAS or ready-made sample. And we did run some basic analyses, descriptive analyses, and we did some visual data as well. So last tips for you guys, just like with anything, practice makes perfect. Especially with softwares like SPSS, they seem very complex and technical, but the more you work with them and you put hands-on experience, the more you learn, and it will become easy for you to use. Seek help and support. There are numerous resources. When I tried to look up something to help me build this presentation, I was surprised with the amount of resources, whether they're videos or forum discussions or user manuals, and a lot of them are free. So make use of that chance. Also, in the world of technology, you know, it's ever evolving, and especially with technology sharks like IBM, they're always competing on providing cutting edge technologies and new features. So I encourage you and myself to stay up to date with these new products, because they make life so much easier. They help us with the data. We get new information that can help us to inform our decisions and help us deal with our patients. And also, I encourage you to apply that knowledge. I know many of us now are already started their projects, their research, whether they're developed the idea or the questionnaire. So make use of that knowledge by practicing now. So when you reach to the point of analyzing your data, you know at least the basic features of the SPSS. Thank you so much for your time, and I'm ready if you have any questions.
Thank you so much, Dr. Seher, for this great presentation. Dr. Leem, go ahead if you have question or comment.
Oh, no.
Any other questions to Dr. Seher or other presenters? If not, we can move on to the next item in the agenda. this great presentation as well. Thank you so much, Dr. Suhair. Grateful.
You're welcome. Thank you, Doctor.
So briefly, any updates before we jump to the last item? Any project or updates as far as what you are doing? Go ahead, Dr. Abul Qasim.
Good evening, Dr. Nader, and to all the other fellows. How are you guys doing? Hoping you're doing fine. We started the project to be a cross-sectional study measuring the knowledge attitude and practice of intraosseous access among junior physicians. Right now we are in the questionnaire designing phase. We have a preliminary questionnaire that I would like for you to check. If that's okay with you, I can send it to you on your email tomorrow, inshallah.
No problem.
We are
Yeah, go ahead.
we are also looking for any fellows working in emergency medicine to help us with the validation of the questionnaire or in any other acute medicine specialty. Thank you.
Sounds good. Thank you. Go ahead, Dr. Lima. Manwasan, go ahead.
Thank you, Dr. Nader. Thank you all presenters for the great presentations. I just want to give some updates about the upcoming webinar event with the upcoming Match application. So we're organizing a webinar with a former program director of internal medicine program. And it will be like next week on Saturday, July 20. And I'm just, we're collecting some questions to, maximally use the time just to submit it for the presenter, just to prepare on the questions. And we're still collecting questions from fellows on our WhatsApp group. So I just want to highlight everybody not to miss that webinar because it's going to be very important for all applicants because we may get some experience from a lot of organizations, but getting specific tips from a former program director with more than 20 years of experience in the specific field will be a bonus for everybody. So I will encourage everybody to attend the webinar and to just post their questions on our WhatsApp group so that we put it on our question list. Thank you.
Thank you so much. So I'm gonna send the link, and it's gonna be a website, and then it's going to be through this meeting, but we will play it on YouTube. So for people outside of the Telegeriatric Research Fellowship, they can follow the webinar online. So I'll give you more information about that, but we will give you the link. So people, even if they are not in this program, they can watch and learn. Maybe they can interact as well. Thank you.
Thanks so much.
You're welcome. If no other comments, we can move on to the topic.
Okay, thank you, Dr. Nader. So now we're coming to the final topic in our agenda today. It will be presented by Dr. Ahmed Amir, and he will discuss with us the chronic heart failure management based on the ESC guidelines. I will be sharing his presentation, so if you can please assign me as host again. Thank you.
Hello, everyone. Do you hear me?
Yes, Dr. Ahmed, we can hear you. Please proceed.
Thank you. I am pleased to be here today to discuss the diagnosis and management of heart failure, focusing on the latest ECC guidelines. In this presentation, we won't focus on the pathophysiology that most of us are familiar with. Instead, our main focus will be on the diagnosis and management. However, we will briefly review some basic definition and important aspect of pathophysiology. So let's start with the definition of heart failure. Heart failure simply is a clinical syndrome consisting of symptoms and symptoms plus or minus signs. So you may encounter a patient with symptoms of heart failure like shortness of breath, ankle swelling, or other cardinal symptoms of heart failure like chronic fatigue. Or you may encounter a patient with symptoms and signs, obvious signs of heart failure, like congested neck veins and basal crepitation on auscultation. There is some points in pathophysiology of the heart failure, maybe due to systolic dysfunction or diastolic dysfunction or both. But the most important one is in neurohormonal activation and remodeling. Next slide, please. There is a lot of risk factor for heart failure, maybe the age, obesity, smoking, and family history. Also, there is a lot of causes for heart failure. The most important one is coronary artery disease, hypertension, diabetes mellitus, and valvular heart disease. So simply, we can divide the causes of heart failure into two groups. Heart failure with ischemic etiology, and the other group, heart failure with non-ischemic etiology. Honestly, I love the first group because heart failure with ischemic etiology, because there is a huge benefit from revascularization. That's why the ECC guidelines were very clear and straightforward in recommending coronary angio for patient with refractory anginal symptoms and patient with intermediate to high risk, high pretest probability of coronary artery disease. They recommend coronary angio for patient with refractory anginal symptoms as class 1A for patient with refractory anginal symptoms. And they also recommend coronary angio for patient with intermediate to high risk to high pretest probability of coronary artery disease as a class 2B recommendation. A class 1A means that the treatment or procedure is indicated. A class 2A means that the treatment or procedure should be considered. And a class 2B means that the treatment or procedure may be considered. So whenever we encounter a patient with symptoms of heart failure, we investigate this patient for probability of coronary artery disease on their ECG or any clues on their echocardiography, like swama at rest or segmental wall motion. If they detect any abnormalities that indicate there is a probability of coronary artery disease, we proceed with non-invasive procedure like tissue Doppler, stress echo, and coronary MRI to assess the viability of the myocardium. If there is, if the myocardium is available, then we proceed with coronary angio for revascularization as the ECC guidelines recommend. Next slide, please. So if there is a suspicion of heart failure based on risk factors, symptoms or signs of the patient, or abnormal ECG findings, the ECC guidelines recommend to measure the pro-BNP and BNP levels as a class 1A recommendation. If there is a high levels of pro-BNP, like more than 125 or BNP more than 35, then there is a probability of heart failure. So the ECC guidelines recommend to proceed for echocardiography. We can start echocardiography, we can from the start, we can order it from the start. If the pro-BNP or BNP are unavailable, or there is a strong suspicion of a heart failure. Based on the abnormalities that have been detected on echocardiography, we can classify the heart failure patient into 3 groups: HIF-BIF group, HIF-MRIF group, and HIF-BIF group. HIF-RIF group is a heart failure with reduced ejection fraction. The ejection fraction is less than or equal 40. And HIF-MRIF, heart failure with mildly reduced ejection fraction. The ejection fraction ranges between 41 and 49. HIF-BIF is a heart failure with preserved ejection fraction, the ejection fraction more than 50, and this group is a group of comorbidities. This group, they have a lot of comorbidities like hypertension, morbid obesity, or chronic kidney disease. Next slide, please. Next slide, please. Okay, thank you. So quite simply, I see the symptoms of heart failure resulting from struggle between 2 teams. One team causes the symptoms and unfortunately has a control and dominance represented by the RAS system, renin-angiotensin-aldosterone system. The other team tries to help the patient and alleviate their symptoms, represented by BNP, brain natriuretic peptide, and other natriuresis like atrial natriuretic peptide. This is where the idea of the pharmacological treatment of heart failure comes from. Once we overcome the ongoing neurohormonal activation, the patient becomes asymptomatic. So the ESS guidelines recommend 4 pillars for HIF-RIF patient, heart failure with reduced ejection fraction. The 4 pillars, the first one pillar is ACE or ARNI. This is a class 1A indication. 4 pillars for HIF-RIF. The 4 pillars are class 1A indication. So they are indicated. The first one is ACE, angiotensin converting enzyme inhibitor, or ARNI. ARNI is a sacubitril valsartan. Sacubitril is neprilysin inhibitor that prevent when we do inhibition of neprilysin, so we prevent the degradation of brain natriuretic peptide and atrial natriuretic peptide. So we encourage the aldosterone escape mechanism. The second pillar is a beta blocker, and the third pillar is MRA, or mineralocorticoid receptor antagonist like spironolactone and eplerenone. And the fourth pillar is the SGL2 inhibitor, like the dapagliflozin and empagliflozin. And they recommend loop diuretics as a class 1, but just for symptomatic relief. The first 4 pillars reduce the heart failure hospitalization and cardiovascular death significantly, but loop diuretics just for symptomatic relief. If the patient is still symptomatic, and the patient on the 4 pillars and still symptomatic, so we can add a class 2 drugs that recommended by ECC guidelines like digoxin, versigate, and ivabradine or hydrolyzine isorbide nitrate, and other drugs. If the patient have ejection fraction less than 35 and still symptomatic despite optimal medical therapy for more than 3 months, and he have a sinus rhythm and the QRS duration more than or equal 130 with left bundle branch block morphology, the ECC guidelines recommend CRTD or CRTB as a class 1 indication. If the QRS is between 130 and 149, it is a class 2 indication. And if QRS with non-left bundle branch block morphology, but more than 150, it is a class 1 it is a class 2B indication for CRTD and CRTB. There is a large proportion of patients with heart failure that die suddenly, even they have a mild symptoms. So the ECC guidelines recommend ICD for primary prevention of sudden cardiac death for the group that still symptomatic despite optimal medical therapy for 3 months and the ejection fraction less than or equal 35 and QRS duration less than 130. So they recommend ICD for as a class 1 indication for ischemic for patient with ischemic etiology and a class 2A for patient with non-ischemic etiology. Next slide, please. What do you think the relation between this picture and our presentation? What do you think the relation between this picture and our presentation? Okay, for the sake of time, I still remember 2 pieces of advice given by our mother, Amal Saeed, a professor of physiology at the Faculty of Medicine, University of Khartoum, in our first day on the medical school. The first advice was, a good doctor is a keen observer. And the second one, you must treat your patient as if you are a tailor, customizing treatment to fit each patient perfectly. The ECC guidelines mentioned that the maximum benefit from the 4 pillars is achieved when we perform up titration to the maximum tolerated doses. Therefore, we should overcome the clinical inertia and reach these highest doses with patients who respond well and don't experience any side effect. Next slide, please. Okay. I have 2 questions on this slide as a take-home message. If you have a patient on ARNI, and this patient is a known case of a chronic heart failure, then the patient has been admitted or hospitalized due to acute exacerbation of heart failure. When do you restart ARNI for this patient? ARNI is a sacubitril valsartan. When to start ARNI for a patient is who a known case of a chronic heart failure that has been hospitalized due to acute exacerbation of heart failure. When to restart ARNI for this patient? Yes. Once a patient is clinically stable, the ESC guidelines recommend to restart ARNI as soon as possible. And they are also recommend to a close follow-up after discharge up to 6 weeks. And they also recommend rapid titration of the 4 pillars even before the discharge. We have to overcome the clinical inertia. The second question, if you have a patient who is on ARNI and improves, would you stop the ARNI or let them continue on it? If you have a patient who is on ARNI and improves, Yes, continue. Why? Because all the improvement that happened was due to the army. Once you stop it, everything will return to how it was before. I have reached the end of my presentation, but I have a note for discussion, especially for colleagues interested in cardiology research. I noticed that first thing that the patients on ARNI ask is about their ejection fraction. They often get very upset if it remains stable, even though their symptoms have completely disappeared. I feel that focusing solely on the ejection fraction is unjust to the remarkable and transformative treatment that ARNI provides. Therefore, I suggest exploring a research idea to investigate the effect of ARNI on other echo findings like the left atrial dimension, LV dimensions, and EA dash ratio. What do you think, Dr. Nad?
I think it's a nice idea. Thank you.
Thank you, Dr. Nader. Do you have any questions?
Thank you so much for another great presentation. Any questions? Any other comments? Any other suggestions? In general, any questions about the program, the TGRF? If not, then I'd like to thank you so much, Dr. Suhair, and your team. I'd like to thank all the presenters from today. You did great work, and I'd like to thank all the attendees. Thank you so much, and also for those who will come and look at the video later. We'll see you next week, inshallah. Thank you. Have a wonderful day. Dr. Suhair, if you want to say anything, thank you.
Thank you, Dr. Nader. Have a good one.
Thank you so much.
Bye.
And thank you for everyone who attended today, and also for those who will come to watch the recording. We're very appreciative of the opportunity. It gave us a lot of space to get to know each other in the team, coordinate with each other, and learn new stuff. So thank you so much, and see you next week.
Thank you so much, everyone.
Thank you. Have a wonderful one.
Thank you, Dr. Nader.
Thank you.
Thank you. Assalamu alaikum.